Okay, imagine this for a second. Your hand just stops listening. The signals from your brain are getting there, but the muscles they don't respond. It's a really devastating reality for anyone with severe nerve damage. But what if you could just bypass that broken wiring completely? What if you could take a part of the hand that's still working and give it a brand new job? Well, today, that's exactly what we're exploring. We're diving into tendon transfers, an absolutely remarkable surgery that literally rewires the hand to bring it back to life.
And this is what we're talking about. You see, when a major nerve gets irreparably damaged, the muscles it controls are paralyzed. This can lead to these really unnatural postures, like the clawing you see right here, which is from an ulnar nerve injury. The hand's delicate balance of forces gets thrown into total chaos, turning it from an amazing tool into a real obstacle. It just profoundly impacts a person's life.
And this is the brilliant question that tendon transfer surgery answers. Instead of trying to fix the broken nerve, what if you could just reroute the ropes and pulleys, the tendons themselves? The whole idea is to take a healthy muscle that's still getting signals from the brain and reassign it to do the job of one that's paralyzed. It's not about creating something new out of thin air. It's about ingeniously repurposing what the body already has.
So let's be really clear about the problem we're trying to solve here. We're talking about permanent nerve injury. This means the connection points between the nerve and the muscle might have just withered away. So even if you could repair the nerve, it has no muscle to talk to anymore. The result? A hand without power, a hand that can't perform the most basic, crucial movements. This is the problem.
And here is the solution: a tendon transfer. It's so elegant. A surgeon identifies what you could call an expendable healthy muscle, one whose job can be covered by others. They detach its tendon, they reroute it, and then they suture it to the tendon of a paralyzed muscle. So now when the brain tells that donor muscle to fire, it produces the movement that was lost. It's an incredible concept, just using the body's own spare parts to restore function.
Let's get a little more specific about what this rewiring actually looks like. I mean, it is a genuine feat of bioengineering. Surgeons don't just randomly move a tendon. They meticulously plan a whole new system of forces in the hand. They have to consider the tendon's path, its strength, its range of motion. It's kind of like borrowing a working engine from one part of a machine to power a critical component that stopped working.
Well, let's look at a classic example. This slide here shows the original blueprint. You see that wrist flexor muscle, the flexor carpi radialis? Its entire job is to bend the wrist. Now, in a patient with a radial nerve injury, this muscle still works perfectly fine. The problem is, the muscles that extend the fingers are paralyzed. The patient literally can't open their hand.
And now for the new assignment. The surgeon detaches that wrist flexor tendon, reroutes it to the top of the hand, and then weaves it into the paralyzed finger extensor tendons. So what happens? It's amazing. The patient thinks, flex my wrist, the brain sends the signal, but instead of the wrist bending down, the fingers open up. The patient literally has to retrain their brain to link one thought with a completely new action. It's a remarkable process of surgical reconstruction and then neuromuscular re-education. Now, this kind of success is no accident, not at all. It relies on a super strict set of core principles. A surgeon can't just pick any old muscle and move it anywhere they want. To make sure a tendon transfer is successful, functional, and durable for the long haul, they have to follow a very specific rulebook. Let's walk through some of the most critical ones.
First off, the groundwork has to be perfect. The skeleton has to be stable. You can't build on a broken frame, right? Second, the joints must be supple. A new muscle can only move a joint as far as you can already move it with your other hand. Third, the soft tissues have to be healthy. A tendon just can't glide smoothly through a bunch of thick scar tissue. And finally, a single clear goal. One donor muscle restores one specific function. This keeps it from getting too complicated and compromising power.
So, how does surgeons pick the right muscle for the job? Well, two factors are absolutely key: power and excursion. For power, the donor muscle has to be strong enough, but not so strong that it creates a whole new problem, a new imbalance. Surgeons know that a transferred muscle will lose about 1 grade of strength, so they account for that. And excursion, that's just a fancy word for the tendon's range of motion, its travel distance. To restore something like finger extension, which needs a long range of motion, you need a donor muscle that can pull that tendon far enough.
And to help with that whole excursion thing, surgeons have this handy guideline called the 3-5-7 rule. Basically, wrist tendons travel about 3 centimeters, finger extensors travel about 5, and finger flexors travel about 7. Now this immediately brings up a problem, right? How can a 3-centimeter wrist muscle power a 5-centimeter finger muscle? Well, the secret is something called wrist tenodesis. When you flex your wrist, your fingers naturally extend a bit. That passive motion adds the extra distance needed. It's a totally brilliant way surgeons leverage the body's own natural mechanics.
And this brings us to a fascinating principle, synergy. You see, the brain is wired with certain patterns. Like we just said, flexing the wrist naturally extends the fingers. They're what we call in phase. So using a wrist flexor to power finger extension is actually pretty intuitive for the brain to relearn. Trying to use an out-of-phase muscle would be way harder for the patient. By choosing these synergistic muscles, surgeons make the whole rehab process so much easier.
Okay, so we've covered the what and the how, and we understand the core principles behind all this. Now let's see how these are applied in the real world to fix injuries to the three main nerves of the hand, the radial, median, and the ulnar nerve. Each nerve injury creates its own unique set of problems, and, as you can guess, each one requires a tailored solution. Let's kick things off with the radial nerve. A high injury to this nerve causes the classic wrist drop. The patient just can't lift their wrist up, they can't straighten their fingers, they can't extend the thumb out. The hand is just stuck in this flexed, non-functional position, which makes it nearly impossible to grasp anything at all.
So the surgical goals are crystal clear. First, you've got to restore wrist extension to position the hand for grabbing things. A forearm muscle called the pronator teres is typically the one they use. Second, restore finger extension so the patient can actually open their hand. That wrist flexor we've been talking about is a common choice here. And third, restore thumb extension to get it out of the palm, often using a small tendon like the palmaris longus. This combination is a real workhorse procedure for this kind of injury.
Next up, the median nerve. Now, the most devastating thing here is the loss of thumb opposition, that uniquely human movement where the thumb swings across the palm to touch the fingertips. It's the absolute foundation of all pinch and grasp. Without it, the ability to pick up small objects is just gone. As you can see in this picture of a successful surgery, restoring this one function is everything.
So the primary goal is restoring that thumb opposition. To do this, surgeons perform what's called an opponentsplasty. They'll take a donor tendon, often from the ring finger, route it around a wrist tendon that acts as a new pulley and attach it to the thumb. This new line of pull perfectly mimics the lost muscle, pulling the thumb into that critical grasping position. It's really clever.
And finally, the ulnar nerve. This injury is tricky because it causes a loss of the small muscles inside the hand, which leads to two main problems. First, you get that clawing deformity of the ring and small fingers because of a muscle imbalance. Second, you get a very weak key pinch. As the image shows, when a patient tries to pinch a piece of paper, they have to compensate by bending the tip of their thumb. That's a dead giveaway called the Froment sign.
So the goals here are twofold. First, correct the clawing. A wrist extensor is often used, lengthened with a graft that's then split into 4 little tails and attached to the sides of the fingers to restore that balance. Second, you have to restore a strong key pinch. Another transfer is routed across the palm to give the thumb its power back. Restoring just these two functions can dramatically improve the hand's dexterity.
Now, it's so important to understand this next part. The surgery, as complex and brilliant as it is really only the beginning. The mechanical connections have been remade, but the software, the brain, it needs to be completely reprogrammed. This is where the patient's journey to recovery truly begins, and it's a journey that takes a lot of patience, a lot of dedication, and a lot of intensive therapy.
The post-op protocol is very carefully staged out. For the first month or so, the hand is immobilized to let those delicate tendon repairs heal up. After that, gentle, active exercises begin. This is the start of the retraining, consciously thinking, flex my wrist to make the fingers extend. Strengthening usually starts around 2 months, with a return to more normal activity after 3. And throughout this entire process, specialized therapy is absolutely crucial to help the brain adapt and make those new movements feel natural. And this really brings us to our final, and maybe the most profound question. We've spent all this time focused on the incredible mechanical feat of reconnecting the ropes and pulleys in the hand. But the true magic, that happens in the brain. The surgery provides the potential for new movement, but it's the brain's remarkable capacity for change, its neuroplasticity, that unlocks that potential. How does an organ that has spent decades firing one set of neurons for wrist flexion learn to use that very same signal to now achieve finger extension? It's just an amazing testament to the brain's ability to adapt, to remap itself, and to find new pathways to restore what was lost.